Assalamualaikum and a very good morning. A warm welcome to all participants from Malaysia, the SEAMEO network, and affiliated countries to today's webinar. The theme for today is Understanding Air Pollution Exposure, Linking Health and Environment. Our presenters today are from the Institute for Medical Research in Malaysia. I am Dr. Nuraisha binti Muhammad Sham, a research officer from Climate Change Unit, Environmental Health Research Center, IMR, and will be the moderator for today's session. I would like to take this opportunity to invite everyone to our environmental forum, which organized by our center. This forum will be held on a hybrid platform on 27 September in conjunction with World Environmental Health Day with the theme Be a Change Maker, Tackling Antimicrobial Resistance is our responsibility. I hope to see you there. Ladies and gentlemen, back to our webinar for today. This webinar series was initiated with the aim in mind to share knowledge, covering diverse research themes, including biomedical, environmental research, and share research outcomes. Today, we have with us two outstanding researchers in the field of environmental health from EHRC, IMR NIH, Malaysia, who will share their work with us related to today's theme. Before we begin, continue further, allow me to announce a few housekeeping messages from the Secretariat. One, we will not be taking any questions during the presentation, but participants may ask questions using the link that we have shared in the email and YouTube channel. Second, the question and answer session will be conducted after the end of both presentations. An attendance link is also provided for those who would like to receive an e-certificate of attendance. And lastly, please subscribe to our National Institute of Health Malaysia YouTube channel and click for notifications whenever there is a new post. Ladies and gentlemen, as I mentioned, for today's webinar, we have two speakers. Our first speaker is Dr. Muhammad Faiz Ibrahim, who is a medical officer in Occupational and Health Unit under Environmental Health Research Center. Dr. Muhammad Faiz is a public health doctor at the Environmental Health Research Center, Institute for Medical Research Malaysia, with the expertise in researching the impact of air pollution and on human health. He is currently pursuing a PhD in public health, focusing on quantifying the risks associated with air pollution and its influence on diseases and health outcomes. Dr. Faiz has engaged in international organizations, including UNICEF Malaysia, where he provided a technical report entitled Impact of Climate Change on Children, a Malaysian Perspective. He is also appointed as a co-consultant by TNB Research to assess the co-health benefits of electric vehicles in Malaysia. Dr. Faiz actively participates in conferences, presenting his research findings, including at the International Society for Environmental Epidemiology, IC, conference, where he discussed the association between air pollution and hospital admissions for upper respiratory tract infections in urban areas of Malaysia. For today, Dr. Muhammad Faiz will be sharing his research experience in his presentation entitled Burden of Lower Respiratory Infections Attributable to Ambient Air Pollution Among Children in the Klang Valley. Dr. Faiz, the screen is yours.
Thank you, Dr. Nuraisha, for that kind introduction. Assalamualaikum and very good morning. My name is Dr. Muhammad Faiz, and I am honored to present our latest scientific work titled Burden of Lower Respiratory Infections Attributable to Ambient Air Pollution Among Children in Klang Valley. Ladies and gentlemen, over a decade, ambient air pollution has emerged as a significant risk factor contributing to the global burden of diseases. with particular concern on the impact of respiratory health, especially children under 5. In 2019, particulate matter 2.5 was responsible for approximately 93,000 LRI death and 8.2 million disability adjusted life years daily. This burden of diseases is not evenly distributed across the globe. It disproportionately affects low and middle income countries, including Malaysia. Despite the worldwide concern, there is a noticeable lack of comprehensive local research, especially in Malaysia urban area. Therefore, our study aims to estimate the burden of lower respiratory infections among children attributable to ambient air pollution in the Klang Valley. Okay, this study has three specific research objectives. Number one, to identify the daily trend of major air pollutant, PM2.5, PM10, CO, NO2, SO2, ozone, temperature, relative humidity, and lower respiratory infection among children in Klang Valley. Number two, to determine the association between air pollution and lower respiratory infections among children in Klang Valley from 2010 to 2019. And number three, to estimate the association between air pollution. Number two is to estimate the burden of lower respiratory infection attributable to ambient air pollution among children in Klang Valley from 2010 to 2019. These slides apply an ecological study with a time series and comparative risk assessment of burden of diseases. This study is conducted in Klang Valley. As there is no universal definition for Klang Valley, we adopted a definition used by Invest KL, an agency under MITI, which includes Kuala Lumpur, Putrajaya, Sepang, Hulu Langat, Klang, Petaling, and Gombak district. The study populations include individuals below 18 years old in line with the Malaysian Child Act 2001 and UNICEF definitions. For the sampling method, we employ universal sampling, meaning we include all individuals who met the inclusion criteria but not the exclusion criteria. The inclusion criteria includes admission to government hospital within the study area for lower respiratory infections with the corresponding ICD-10 codes J09 to J18 and J20 to J22. Number two, mortality due to lower respiratory infections with the same codes. And number three, the individual had to be below 18 years old during the study periods. Now, let's move to the exclusion criteria. Number one, being born with congenital malformation, deformity, and chromosome abnormalities. Number two, mortality resulting from external causes. And number three, patient admitted to UPM, teaching hospital, and military hospital were also excluded. This decision was made due to restriction of the data availability from this hospital. These slides show the location of the continuous air quality monitoring station and hospital included in our study, as well as the study area. The major air pollutant data, along with relative humidity and temperature, were obtained from the 6 fixed monitoring stations operated by the Department of Environment. Hospital admission data were collected from 12 hospitals located within the 15-kilometer radius from the monitoring station. Please note that the mortality data within the study area were obtained from the Department of Statistics Malaysia. This slide shows the research flow for our study. First, we begin with data collection and data processing. All relevant data were collected from the respective agency and any missing data were treated for the time series regression to ensure the accuracy of the data. Moving on, we focus on the estimating of the relative risk between ambient air pollution and lower respiratory infection. Next, our attention turned to the quantifying of the population attributable factor. This measure allows us to determine the proportion of lower respiratory infection cases attributable to ambient air pollution. Furthermore, we estimate the DALI for lower respiratory infections within our study population. And finally, we're connecting the dots we specifically estimate the daily attributable to ambient air pollutions, and a subgroup analysis were also conducted to identify the susceptibility subpopulation for more targeted public health intervention. Ladies and gentlemen, this slide presents the formula of the quasi-Poisson generalized linear model with distributed lag model utilized in our study. Firstly, we specified the core model with a quasi-Poisson for all groups, which include all children, boys, girls, 0 to 4 years, and 15 to 17 years. This model includes a natural spine smoothing function for time with 4 and 8 degrees of freedom per year. The selection of degree of freedom are based on QAIC criteria. To adjust for the effect of temperature and humidity, we utilize the natural spine function with degree of freedom 3 for temperature and relative humidity. To control other confounders, we control a day of weeks, holiday, and influenza. Ladies and gentlemen, this slide shows the formula for estimation of population attributing factor. The PAF is obtained by subtracting the relative risk of the theoretical minimum risk level from the RR of the proportion of exposed individual in the study area and dividing it by the RR of the proportion of exposed individuals. We made an assumption that the proportion of the exposed individual is 100% based on previous study on the population weightage exposure level of PM10 in Klang Valley, which met the national standard but not met the WHO recommendation. The theoretical minimum risk level, or TMREL, is the level of exposure that minimizes risk at the population level. In this study, we define the TMREL as equal to the first percentile of observed concentration. Ladies and gentlemen, this slide explains three components of disability adjusted life years, or DALI, namely years of life loss, YLL, and years life with disability, YLD. YLL represent the years of life that are lost due to premature death. It is calculated by multiplying the number of premature death by the standard life expectancy at the age of death. The idea is to estimate the potential years of person could have lived if they had not died prematurely due to lower respiratory infections. YLD represents the years life with a specific health condition or disability. It is calculated by multiplying the prevalence of lower respiratory infections by the disability weight for the condition. The disability weight reflects the severity of health condition, with 0 representing perfect health and 1 indicating the state of health equivalent to death. YLD helps quantifying the burden of non-fatal health condition and provide insight into the impact of disability and population health. DALI are comprehensive measure of the overall disease burden in a population. They are calculated by summing YLL and YLD for lower respiratory infection. This slide shows the formula for the attributable YLL, YLD, and DALI for lower respiratory infections using the PAF. As you can observe, the attributable YLL, YLD, and DALI are related to ambient air pollutions for lower respiratory infections can be obtained by multiplying the YLD, YLL, and DALI for lower respiratory infections with the PAF. It is essential to emphasize that in this study, we only include the significant pollutant variable identified in the time series regression. This slide illustrates the daily concentration of air pollution in Klang Valley from 2010 to 2019. A simple natural spine smoother was added to this to show the general trends. During this period, there were several peaks of PM10 level that exceed the Malaysia ambient air quality standard. A similar pattern was observed for the daily PM2.5 level, which can attributable to the methodology used to replace the PM2.5 value using the PM10 to PM2.5 ratio of 0.72. In terms of SO2 level, the Klang Valley consistently exhibit relatively low level throughout the study period. No value were observed to exceed the national standard. Notably, that lowest trend for SO2 was observed in 2019 when compared to the previous year during the study period. The pattern of NO2 level differ from the SO2 level as described previously. The daily average of NO2 exhibit fluctuations and show a decreasing trend from 2017 to 2019. Similarly, the ozone level in the Klang Valley also display a fluctuation but consistently remain near the national standard level. However, unlike NO2, there was no distinct decline in the ozone level from 2017 to 2019. For the CO level in Klang Valley, remain well below the national standard. For 2017 to 2019, there was a slight increase in CO level. The change in the pattern of CO and O2 and NO2 were likely influenced by the application of the new monitoring station by Department of Environment in the middle of 2017. This slide displays the daily trend of lower respiratory infections, hospital admission, and mortality in Klang Valley from 2010 to 2019. The daily hospital admission for lower respiratory infection exhibit a seasonal pattern with an increase at the beginning of each year and decreasing trends toward the end of the year. This pattern is likely influenced by various factors such as climax, school holiday, and seasonal influenza. Ladies and gentlemen, this slide display this slide shows the result of Spearman correlations. Tests reveal that significant correlation among all air pollutant and meteorological factor with exceptions of the CO and temperature. The highest significant correlations observed in Klang Valley was between PM10 and PM2.5. It is important to note that these high correlations between PM10 and PM2.5 was attributed to the imputation method used to fit the missing value based on PM10 PM2.5 ratio. Additionally, a significant low negative correlations were found between relative humidity and all air pollutant except for NO2 and CO. These negative correlations suggest that dry condition could potentially lead to an increase in the concentration of air pollutants. This slide summarizes the result of the single pollutant model for the association between lower respiratory infection cases and air pollutions. Significant correlation were found between exposure to SO2, NO2, and ozone and lower respiratory infection cases. The highest RR for SO2 were observed at cumulative lag 0 to 5 days with RR 1.042. For NO2, at cumulative lag 0 to 5 days with RR 1.01. And for ozone, at the cumulative lag 0 to 6 days with RR 1.005. Ladies and gentlemen, this slide displays the three-dimension plots of RR and lower respiratory infections from the single pollutant model at lag 0 to 6 days. Adverse effects were observed on the same day and gradually dismissed after several lag days. The RR for SO2 was the highest among the three pollutants, but exhibit a faster decline. On the other hand, the ozone had the lowest RR, but its decrease was relatively slower after 6 days. This slide provides a comprehensive summary of the annual DALI per 100,000 population for lower respiratory infections attributable to SO2, NO2, and ozone in children for both gender aged 0 to 17 years in Klang Valley from 2010 to 2019. Noted, uh, it is noticed that SO2 merged as the primary contributor to the rate of lower respiratory infections attributable to ambient air pollutions for during the study period. This observation could be attributed to the high demand of electricity consumption in the densely populated Klang Valley. The prevalence of modern concrete house occupied with air condition and electrical stove may indeed contribute to the high energy consumption, which in turn can lead to increase of SO2 emission. This emission can arise from the burning of fossil fuel in the power plant to meet the energy demands. Over the study period, we did not observe any noticeable trend in the DALI for all the air pollutant considered. This slide demonstrated the estimated lower respiratory infections DALI attributable to air pollution stratified by gender from 2010 to 2019. The blue bar represents boys, while the pink bar represents girls. This finding emphasized that both boys and girls are equally affected by ambient air pollutions. Gender does not seem to be a differentiating factors in the burden of childhood lower respiratory infections attributable to air pollutions. This slide represents the result of stratified analysis by age groups. The orange bar represents children under 5, while the brown bar represents children aged 5 to 17 years old. In the age group stratified analysis, children younger than 5 years old had higher DALI for lower respiratory infections for SO2, NO2, and ozone than children aged between 5 to 17 years throughout the study period. This highlighted the vulnerability of among among infant and young children that can be attributed to their immature lungs and higher breathing rate, which increase their exposure to ambient air pollutants. This factor, combined with underdeveloped immune function, may make infant and younger children more susceptible to adverse health effects of air pollution. These findings underscore the importance of focusing on protecting the health of our youngest members in the populations from the impact of air pollution as they face higher risks and they are more vulnerable to the health consequences of exposure to harmful air pollutant. In conclusion, this study underscored the significant impact of air pollution on childhood lower respiratory infections in Klang Valley. Our findings highlight that SO2 exposure emerged as a primary contributor to the burden of childhood lower respiratory infections in the study area. Moreover, we have identified young children as vulnerable population group, particularly susceptible to the health effect of ambient air pollutions. To address this concern issue, urgent environmental intervention are vital. Targeted measures focus on reducing SO2, NO2, ozone level are crucial to mitigate the adverse effects in the study area. By taking prompt and effective actions to tackle air pollution, we can safeguard the respiratory health of our children and improve the overall well-being of our population. I would like to express my gratitude to the Dean of Faculty of Medicine at the University Kebangsaan Malaysia for allowing and funding this study. I'm also thankful to the Director General of Health Malaysia for granting permission to conduct and present this research. And to the Malaysia Department of Environment for allowing us to use the air quality data. Additionally, I want to acknowledge the Director of Institute for Medical Research, IMR, for giving me opportunity to present my finding on this platform. With that, thank you, and the screen back to Dr. Nuraisha.
Thank you, Dr. Faiz, for sharing his findings. A soft reminder, if there is any questions that you would like to ask about his presentation, kindly fill up the form using the link given in the YouTube channel. Next, I would like to introduce our second speaker for today, Ms. Farah, Azmi. Ms. Farah is a research officer at the Environmental Health Research Centre, IMR, Malaysia. She has been part of IMR since 2011. She holds a Bachelor of Science with Honours in Environmental Science, majoring in Environmental Chemistry, and a Master of Science in Environmental Assessment and Monitoring from Universiti Kebangsaan Malaysia, UKM. Her research mainly focused on assessing chemical pollutants in air and water and their impact on human health. Currently, she is pursuing a PhD in science at Taylor's University. She is now broadening her research field to incorporate mathematical modeling for air pollution with the goal of creating a comprehensive model for predicting air pollution exposure. It is our great pleasure to have Ms. Farah with us to share her experience. Her presentation for today is entitled Land Use Regression Model for Air Pollution Exposure Assessment. So, without further ado, over to you, Ms. Farah.
Thank you, Dr. Aisha, for kind introductions. Assalamualaikum and good morning. My name is Nurul Farah, Research Officer from Environmental Health Research Centre, IMR. Today, I would like to share my research project on land use regression model for air pollution exposure assessment. This project is a collaboration project between IMR with Taylor University and Universiti Kebangsaan Malaysia. Ladies and gentlemen, in Malaysia, air pollution level are monitored by Department of Environment Malaysia through a network of continuous air quality monitoring station (CAQM). The CAQM stations monitor several types of air pollutants such as nitrogen dioxide, sulfur dioxide, carbon monoxide, ozone, and particulate matter. There are 65 stations in Malaysia, and the station located strategically in residential, traffic, and industrial area. And the station cover about 5 km radius of nearby area. Air pollution has widely known poses significant impact to human health, especially for cardiorespiratory diseases. Typically, the population exposure to air pollution are determined based on the air monitoring station. However, the monitoring stations are limited into certain locations and only cover about 5 km radius. And the station also only provide air pollution level and did not describe the spatial information. As we know, to conduct the exposure assessment, several factors has to take into account such as spatial variations and air distribution variability. With the emerging of GIS technology, the application of GIS technology and to incorporate with mathematical modeling to produce the spatial modeling has become valuable tools to estimate air pollution level in unmonitored area and to determine the population exposure. There are several types of air pollution exposure model, such as proximity model. This type of model is straightforward model where they estimates pollutant from nearby sources, but the model use a restricted number of covariates. Second, interpolation model. This model estimates pollutant distribution based on the existing observation data, but the model requires a lot of number of sampling sites to smooth their data. And then a dispersion model. This model that calculates pollutant dispersion from emission sources, and the model requires meteorological input, emission inventory, and detailed knowledge on physical chemical process. And lastly, the land use regression model. This model estimates pollutant based on data from station, and then they include and consider the spatial background. But the model is less compatible when we try to apply to study area with much different land use and topography. 4. In this study, we developed land use regression model for PM10, and this model is developed for Peninsular Malaysia and only include the spatial data of land use, road and population. For this study, we have two research objectives. First, to develop land use regression model to measure air pollution exposure level. Second, to evaluate the performance of developed model in terms of prediction ability. For the methodology, we have 4 stages. First stages is pre-processing, which involve the GIS analysis. Second, performing the modeling. Third, we evaluate the model. And then lastly, we produce the pollution map. For data collection, we have 4 types of data. For air pollution data, we collected from Department of Environment Malaysia. We collect PM10 data from 34 monitoring stations in Peninsular Malaysia. And for the road type, network and road length, we collected the data from Ministry of Work Malaysia. For the population density data, we collected from Department of Statistics Malaysia. For the type of land use data in Peninsular Malaysia, we collected from Malaysia Centre of Geospatial Data Infrastructure. For the data, for the predicted variables, we include a road network, population density, and land use. For the road network was divided into primary and secondary road, and then we create the buffer around the monitoring station. And the buffer that we are used are 100 meter, 300 meter, 500 meter, and 1,000 meter and 5,000 meter radius around the monitoring station. Similar with population density and land use variables. For the land use, we categorize the land use into 10 categories: industrial, residential, commercial, forest, water body, infrastructure, institute facility, transportation, agriculture, and forest or green area. For pre-processing data, we process the data in the GIS software. First, the air monitoring station, we geocoded the monitoring stations based on the location. Second, for the land use layer, we identify and classify type of the land use. And then for the road network, we classify type of road as primary or secondary and calculate the road total length. And then for the population layer, we calculate population density as person per radius. After that, we create the multiple buffer and then extract data value by buffer area to the monitoring station. So this is to show you how we do it in the GIS software, where we create the buffer from the monitoring station, 100 meter, 300 meter, 500 meter, 1,000 meter, and 5,000 meter, and then we extract all the variable value. And then we include the variables in the regression models. So for the regression equation, y, the response variable is PM10, and the x is the predictor variable. We include the land use area, about 50 variable, road length, about 20 variable, and population density, about 5 variables. And then for the model validations, we use a leave one out cross validation approach to evaluate our model. We create 8 sets of data set with 1 left outside, and then the model structure remain constant for each estimate. For each experiment, we use n-1 site for training and remaining site for testing. And then we calculate the root mean square error to determine the prediction error. And then this is the final land use regression model that we obtain. From the model, we can see that there are four variable has been included. The four significant variable has been included to the model to attain the good fit models. From the equation, we can see that industrial area within 5,000 meter, secondary road within 5,000 meter would cause increasing would influence the PN10 to increase, while the infrastructure within 5,000 meter, forest or green area within 5,000 meter would negatively correlated to PN10. And then from the plot between measure versus predicted value of PN10 concentration, we can see that R square, our R square that we got is 0.585, and then RMSE equal to 5.628. And then for the validation models, this data set that we train, we can see the LOCCV or the cross validation R square equal to 0.56573, and then the difference between the model R square and the validation R square about 0.5% to 1.2%. This is to show that our model is robust enough when we process the data. When we compare our study with other study, our R square is about 0.59, and then our significant predicted variable industry, road, green area, and infrastructure. We can see that in Indonesia and in Iran, the R square are a little bit lower than our study. And then in China and in Europe country, they are a little bit almost similar or higher than our study. But from all the study, we can see that industry, road, traffic are the most significant predictive variables, while the green area and the humidity were negatively correlated with the pollutants. And then this is the pollution map that we are produced. We can see from the distribution, we can see that from the level of PM10 in the Malaysia, in urban area, the PM10 level are much more higher. For this, the location in Selangor, Kuala Lumpur. This is the urban area. We can see the concentration are much more higher other than other area. And then we can see in the northern Peninsula Malaysia, the level are much more lower. From the model, the results show a good fitness of the model and robustness in predicting PM10. However, this study is limited to only PM10 pollutant, and in a further word, we will expand for other pollutants. And then also this study only include Peninsula Malaysia, and for further work, in the future work, we would like to develop model for Eastern Malaysia like Sabah and Sarawak. That's all from me. I pass to you, Dr. Aisha. Thank you.
Thank you, Ms. Farah, for the insightful presentations and findings. We will now moving to questions and answer sessions. Please keep sending us your questions using the link provided in the YouTube channel. And I will try my best to connect you to our distinguished speakers through the posted questions. However, if the times does not allow us to address all the questions, our speakers will try their best to answer the questions through the email. Okay, now it seems like we have received a few questions from our audience. The first questions is for Dr. Faiz. Okay, the questions are, what are the pathophysical logical mechanisms through which air pollutants that can affect the respiratory systems and contribute to respiratory diseases, including LRIs? From Dr. Aizat, JKN Johor. Dr. Faiz?
Okay, thank you to Dr. Aizat for such good questions. Okay, there are several pathophysiological mechanisms throughout which air pollution can affect respiratory systems. However, I'll just mention a few that are most significant. Now, the first one is actually inflammation and oxidative stress. So, by inhalation of these pollutants, it will activate the ROS and then will induce the oxidative stress, which then leads to this cells injury. So, due to this cells injury, our respiratory system are more prone to inflammations and the development of diseases. The other mechanism is just with a simple irritation due to the pollutants, which can cause like irritation, sore throat, sneezings, and coughings. And then one of the most recent mechanism is the epigenetic changes due to the air pollutants. This will change the gene expressions and will lead to the development of respiratory diseases, especially in chronic diseases such as COPD. I think I hope I answer the questions. Yep. Back to you, Dr. Raisha.
Okay, I hope that the answer suits to the questions. Okay, there's another one more question for Dr. Faiz. Okay, LRI hospital admission data was used. However, in the first formula, you can only use influenza admission data were mentioned. Can you please describe more?
Okay, thank you, Mr. Wan from Ministry of Health. I'm sorry for the confusions. Actually, if we look back at the models, we include both hospital admission and mortality for lower respiratory infections, and we control the model with several covariants: time, day of weeks, and time, day of weeks, and then holidays, temperature, humidity, and influenza. So the influenza is actually is a control variables. In this study, I forgot to mention that the influenza, we define influenza with a 95 percentile of influenza cases per day, or a total of more than 95 percentile for 3 subsequent days. Because when we see the trend of the lower respiratory infections, it looks like there are influence with the seasonal pattern of influenza. So that's why it is very important to look back at our data and control for any potential confounders. That's all. Thank you.
Okay, thank you, Dr. Faiz, for explaining. Okay, we have another question for Miss Farah. You have mentioned several types of exposure models. When it comes to selecting exposure models for a research project, how do you determine which model to utilize? Ms. Farah?
Yeah. Thank you for those asking questions. Actually, for to select the exposure model is based on what's your objective or what you want to find in the model. For example, if you want to determine to estimate the air pollutants in unmonitored area, then you can use whether uh, interpolation model or proximity models. But if you want to look into more factor like the background of that study area, the regression model is much more suitable. And if you want to see how much emission from the sources the effects the level, and then you can use the dispersion model. I hope that will answer the questions. I pass to you, Dr. Aisha.
Okay, thank you, Ms. Farah. We have another question for Dr. Faiz. Um, what are the LIRs included in this study? Is TB and COVID-19 included? Dr. Faiz?
Thank you, Dr. Nuraisha, and thank you for the questions. Okay, LRI in this study, so we include the short question is no, we did not include TB and COVID-19s. So we define the LRI in these studies based on the ICD-10 code J09 to J18s and J20 to J2022. So these codes are not include TB and COVID-19 is not included in this code. Not to mention that our study period is from 2010 to 2019, which is before the COVID pandemic. So thank you. Back to you, Dr. Naresha.
Yes, thank you, Dr. Faiz. Um, okay, another question for Dr. Faiz. Is there a link between poor air quality and worse health outcome from COVID-19? From Nurani, UM. Dr. Faiz?
Okay, thank you, Dr. Naresha, and thank you, Nuraini, for asking these questions. This study does not, as I mentioned earlier, that the study period in this study does not cover the pandemic of COVID-19, but to my knowledge, from research from others researchers, have found there is an association between air pollution and COVID-19. Because previously also people have studied that air pollution can have affected or increase the risk of infection due to viruses. In our study, we did not look at the association between air pollution and COVID-19, but from to the best of my knowledge, there is air pollution can increase risk of infections due to COVID-19. Thank you.
Okay. I think all the participants are very interested on your study, Dr. Faiz. There's another question. Just now, Dr. Faiz mentioned that the increases of LRI were due to climate, school holidays, and seasonal variation. Do you have any evidence to support your statement? You want to answer this one first, Dr. Faiz?
Okay. Thank you, Dr. Naisha. All right. So there's two questions there. Okay, we'll answer the first question first. Uh, okay. To this is when we based on the literature, based on our literature review, there is associations between lower respiratory infections and a climate variable, for instance, temperature and also humidity. Holidays and also the seasonal holidays also can influence the actually it's not directly influence the lower respiratory infections, but also can influence the emission of the air pollutants because during holidays most of the factories are closed and in the city center or in the urban area there's less traffic during holiday. So these patterns can influence the air pollution, and that's why it is important to control this variable in the models. Okay. The second question, Dr. Naresha.
Yes, I agree with that. Okay, another question from the same person. What are the best targeted environmental interventions to solve the issue of SO2 pollution in the studied area?
Okay. Thank you, Dr. Naresha. This is a very good questions. SO2 is mainly due to stationary sources such as industry and power plants. So there is it's a very dynamics. There is no one short solutions for that. But one of it is either strict regulations, strict implementation, and also the use of the current technology to reduce SO2 emission from these stationary sources, especially industries and power plants in Klang Valley. Okay, thank you.
Thank you, Dr. Faiz, for the explanation. Okay, back to Miss Farah. There's another question. Could you explain why the closer buffer to the monitoring station does not significantly influence the pollutant level? Miss Farah.
Yeah. Thank you, Dr. Aisha. Actually, for these land use regression models, the the model is calculated based on the total area in kilometer square. So, if the if the variable the variable is not influenced, means that we need more the more we can say that the more like industrial area is the more industrial area, the more it's influence the PM10. So which mean that within in 100-meter buffer or 300-meter buffer, there is not enough industrial area to influence the PM10. So when we go to more bigger buffer like 5,000 buffer, so there'll be increasing the area of the industry area. So within that buffer, so the the industry area is much more influenced to PM10, which mean that in kilometer area square, we calculate in kilometer square. Yeah, I hope that's answer those
Yeah,
questions.
yeah. If I would explain more, it means that if you have a bigger area, more industrial parties inside that area would influence the estimated PM10. Is it true?
Yes, yes.
Okay.
Thank you.
Okay. I think we have more questions from the audience. However, this is the last question goes to Dr. Faiz. Okay, the question goes, hi Dr. Faiz, you mentioned how epigenetics can affect gene expression due to air pollution. In this study, have you measured any gene expression and epigenetics related to air pollution? Okay, Dr. Faiz.
Thank you, Dr. Naraisha, and thank you, Nur Hashima from IMR. Okay, no, we did not include any epigenetics changes in our studies. And actually, there's a very few studies on epigenetics and air pollutions in Malaysia. So there's a research gap. And I think that's a research area that we are really looking forwards, and I personally will welcome any collaborations on the study of epigenetics and evolution in future. Right. Thank you. Back to you, Dr. Natasha.
Okay, I hope that answer from the question from Puan Nur Hashima, IMR. Okay, I am afraid that all the time that we have for questions from participants, any additional questions will be answered by speakers through the email. Okay, we hope that this webinar has shed light on some research work that we are conducting in IMR and would spark interest and could initiate research collaboration with others. Ladies and gentlemen, now we have come to the end of the webinar session. I would like to thank all participants for their support to make this session successful. Don't forget to subscribe to our National Institute of Health Malaysia YouTube channel and click for notifications whenever there is a new post. We hope that you can join us at the next session. Stay tuned for our updates. Until then, many thanks from all of us at IMR. Take care and stay safe. Thank you.